ECMO depending on the requirement. Then we have the durable ones, which can be either LVAD or the RVAD. I will not be going much detail into it. And then the heart transplant. So to understand these therapies, I would just try to get into these main nomenclatures, which everyone should be aware of. So these are very basic things for our heart failure surgeons, which we want to classify the patient on what category he is. So if you just go through this, the intermax 1 to 5, you can say almost 1 to 4 or 1 to 5 is a situation where patient can slowly get deteriorating. 6 and 7 are usually the stable patients who are maintained on medications and all. So extrapolating to the different classifications, we can see that N1 to your emergency or your hospital for the first time, where he may have to be introduced into a mechanical circulatory support depending on his situation. So selection of the patient, not only the selection of the patient, selection of the type of therapy and selection of the correct timing of your therapy. These three aspects are very important, which we will try to discuss and which we'll try to I will try to elaborate in my talk. So we will be just going through all these topics. The advanced heart failure. What are the advanced heart failure therapies? The physiology of the myocardial function, which is a topic of much interest to me. This physiology has been taught to us in the first year MBBS, and it keeps always coming to us all throughout of our life, whoever is a cardiac surgeon or a cardiologist, which is very essential. And I keep telling each of my students that you should keep on looking after the physiology, because that tells you how you can plan your therapy. And why do we need this mechanical circulatory supports? Because it is a costly therapy. Is it really required for patients? The other aspect is cardiogenic shock is one of the main aspect where we need. Yeah. So you can see that this is the diastolic phase where the LV is getting filled. Then we have the isovolumic contraction where the pressure increases but there is no filling. And then there is a sudden ejection where the aortic valve opens, and then relaxation where you can see the pressure falls with not much filling. So this is a normal cardiac cycle, which the trapezoid shape, which we should be very well, this is the base on which most of our discussions will happen. Now when we have an acute myocardial infarction or a cardiogenic shock, basically we consider more of a cardiogenic shock or heart failure related to acute myocardial infarction, which is most common. What happens is we can see that the graph becomes like this. So this indicates the stroke volume of the heart, which it has come down so much, and you can see the end diastolic pressures have also gone up. The volume, you can see the systolic volume has also come down. So if we can see, this is called the potential energy or the area in between the graph, and this is the stroke work of the heart. So once in a heart failure, what happens is the myocardium is weak, it is not getting the blood supply. Most of the energy is going into the potential energy is going for the heart muscle in its relaxation and contraction, because the heart has become stiff, and it is just like once you are weak, it takes so much of energy to lift your hand or lift your leg, but you will not be able to do it when you are in a normal situation. So effectively what happens is your stroke volume is come down, and so your cardiac output comes down. So with this basic thing, I would just like to go into why are we want to get into this mechanical circulatory support for a heart failure patient. See, if you can see the median survival of any patient who has gone into heart failure, especially, and you can see after the first hospitalization, his survival is only for 2.5 years. then it would be very nice to take a decision. Other than that, all the causes of myocardial dysfunction, which can be MI or acute MR, septal rupture, acute ventricular failure due to myocarditis, transplant rejection, or rapidly progressing diabetic related cardiomyopathy, stress myopathy. So all these factors are there. There are some situations like post-cardiac surgery. We have seen this post-cardiac surgery, patient is not able to come off bypass, or he starts deteriorating 5 to 6 hours post-bypass in the ICU. We don't have any other option other than installing a mechanical circulatory support, like putting him on a VA ECMO, and then wait for his myocardium to recover 1 or 2 days, and surely he comes out of all the acidosis and lactates going up and all get washed out. If the renal problem is there or he's not having renal dysfunction, we can always initiate the dialysis along with the mechanical circulatory support. This answers the question which last they were asking, no, what do you do, whether there is any role for diuretics in cardiogenic shock. So in cardiogenic shock, there is not much of a role of diuretics. There is not much a role of dialysis also, because you are not having a baseline. You need a pressure head. The pressure head is not available. So the only way you can get a pressure head is you give support to the heart, support to the circulation. So this is all the list of the indications. Then coming to what are the indications, how we go what are the different criteria in which we want to put this mechanical circulatory support. Now, once you are putting a mechanical circulatory support, you should always know what is the exit strategy. That is the first important thing. Now, if you get a patient who is 75 years and he is in cold clammy, and you know that you can't put a permanent device, or he is not a candidate for a transplant, or you know that he's gone into a severe renal dysfunction and severe hepatic dysfunction, or if he's having even stroke, you don't know if his pupils are dilated, you cannot put a mechanical circulatory support for him, because after his heart and circulatory system have recovered and you find that he is not neurologically awake, so there is no point in getting into that therapy. So we have to see this as a bridge to bridge. Bridge to bridge means you put an ECMO as soon as the patient comes, and then you think what next if he is recovering from that, or you put an IABP, and then once you put an IABP, he has stabilized, his ECG is stabilized, then take him for do the diagnosis, doing a cath lab or anything, do the angiogram, then bridge to recovery. We keep coming across these patients, acute myocarditis, viral myocarditis, peripartum cardiomyopathy. We just put them in ECMO, 4-5 days, they recover. The myocardium is very well recovered, ejection fraction being 20%. In 4-5 days, it becomes almost 45-50%. We can wean off the ECMO, and then patient goes home. So the role of this temporary mechanical circulatory support is gradually becoming more and more increasing, and even patients are getting aware. Then the bridge to decision of therapy. Like once you know that this patient is not coming out, then you have to take either the decision whether we have to do a transplantation or whether he needs an LVAD, depending on all his other parameters which we study later on. So to understand the different types of mechanical circulatory supports which are available to us, most of them is the IABP, then the IMPELLA which is there. Tandem heart is the one which surgically we put. I just want to give a general outlook about it, and the next is the ECMO. So IABP, everyone knows it is a counterpulsation balloon which is inserted